What is the first step in chronic care management?
So the first step of developing this comprehensive care plan is the beginning of chronic care management. And now the nurse will be assessing that and talking to the patient and building these individual encounter plans with every contact.
The annual wellness visit is a good place to introduce the program to the patient.
That add-on code that's money that you get paid for developing this comprehensive treatment plan for your chronic care management services.
Right.
The GO 506, the physician has to do that, but they don't have to do it face-to-face, or is that done during an annual wellness type thing?
That's during the annual wellness. It's an add-on to the annual wellness.
Right. That could be that RN. That's amazing. Wow. It's unbelievable, but this kind of support is available to doing what's right for the patient and what produces quality for the country, because they won't go to the hospital and break the bank. It's exciting, but it's heartrending that this is going to be so difficult in some respects because it's a mean change in doctors' habits, but that we can't make it the old way.
The importance of the base CPT 99490 monthly CCM billing code.
Every visit encounter has to have a plan that is physician developed and very specific for that patient. It's got to be communicated and followed up on, and that's the kind of information you want on the CCD, so your chronic care manager can easily follow up on the physician's treatment plan and then communicate back to the physician. So it's relevant information that's communicated quickly and easily. It's that combination that really makes this methodology or process both very quality producing for the patient and efficient for the doctor. Because if you just follow the long-term plan, you miss that nuance of what we saw this last time when the patient was in, that we have to have more immediate follow-up. So that's what gives that monthly 20 minutes the credibility and the patient's buy-in. So it's relating it to whatever's happened in the previous visit, and that in light of the long-term treatment plan really give this chronic care manager all the information that both the chronic care manager will really get good at and provide the relevant information so the physician is both efficient and has correct data, complete data.
What is the impact to a practice of a Medicare billing code that requires a patient copay?
It's against the law. When Medicare had a copay and I wanted to absorb it and say, just pay Medicare, that became illegal. It was in a patient visit that if I didn't collect that copay, that was fraud. The patient has to pay it. And the second thing is, if the patient was unable to pay it, I had to have proof of trying to collect it. I couldn't just say patient unable to pay, so we just write it off. We had to have documentation supporting the fact that we tried to collect it.
Is it the same for a non-face-to-face consultation?
The thinking is the same. If I can get the patient not to pay their copay, I'm going to bill Medicare like crazy, and the patient doesn't have any skin in the game.
Of the patients requiring complex care, what percentage would typically need the PCP's time beyond a 1-hour consultation?
Basic assumption, you're going to talk to all your complex patients an hour and your non-complex, your 20 minutes.
I mean, maybe a doctor would push back an hour and a half is too much to think that you have to, but these people with 4 to 6 chronic diseases, they come in every 6 months and they're a train wreck, and they take an hour, hour and a half, or the physician just has to cut it off, and they don't get the care they need. And so now I don't think an hour and a half is unreasonable, but you just won't need to see somebody in this train wreck condition if you're having your staff keep up with them on a monthly basis. Somebody might challenge you, 50% is a lot, 20% I think is conservative. As this becomes a true process for this clinic, they're going to be able to stay on top of things.
What are your thoughts on Medicare's coding support for the transition of care patients from episodic care back to primary care?
The other thing that's so valuable here is the fact that this is what it takes to really take care of a transition patient, the transition of a patient. If you don't get paid extra and you don't spend the time that's necessary, or really the clinical staff's time, and pay for their time, the patient doesn't get the care they need and everybody loses. So it's not like we're just adding fluff. You're getting paid for what needs to be done. And so I don't think it's pie in the sky at all to expect a $50,000 another revenue stream coming from now that CMS has funded this revenue stream. It's shifting everything from hospitals and ERs back to primary care. And primary care, the only way we're going to do it is having the staff to handle it. And the only way we're going to have the staff is to get paid like this for the staff.
Do you think CMS would discontinue reimbursement for these treatment activities?
I don't think CMS is going to go back on any of this value-based reimbursement, ACOs, chronic care management. They know this is the outpatient world, and they cannot go back to really enhance an inpatient world. Lack of staff, you just can't do a very good job. This gives you the staff, and they get used to doing this, and they can do a better job than we've ever dreamed.
What would you like to see or discuss the next time we meet?
One of these times, could we look at a typical primary care practice and see what the costs are and how much their revenue expectations would be? In say a typical 2,500 panel primary care, family practice office would say 35% Medicare. It just is a way to start thinking what the numbers would look like. Our initial numbers that it would take 2 RNs, and in this kind of work, I don't think you can go to an LPN, so we're assuming an RN at $40 an hour. And maybe it doesn't have to be an RN. An MA's time counts, and anybody talks to the patient. I might be off in saying it has to be an RN, but most of chronic care management we see done by a system, an outside system, is done by RNs. Say 1 full-time RN and 1 full-time LPN. It's probably 22, 23, and I came up with 2 based on 2,500 panel. You still see that out there.